It's Dr. Bill with just the tip of urology school. And on this segment, we're going to discuss a few of the basic medications we will be seeing in the urology clinic, as well as a really short segment on contrast allergies used for imaging. And let's get that out of the way. Intravenous pyelogram or CT scans with contrast. Commonly, we'll have iodine. If you give that intravenously, there's always that chance of an adverse event. Also, nephrostograms or retrograde urethrograms that are placed under very, very high pressure. Sometimes we can see patients experiencing a venous backflow with the contrast, and they also can be subject to a contrast allergy. Usually not a big deal, maybe a little bit of tingling or feeling of warmth, sometimes a rash or swelling of the lips. Usually Benadryl will be all that's required with a little bit of reassurance by the patient, keep them monitored. Unfortunately, some of them, but rarely, can go to anaphylactic shock. So it's really important for all of us who are involved with urologic patient care to be aware of some of the protocols we have in our office and our radiology department. And certainly you can see the resuscitation protocols that are on the AUA website that I'm always referring to. We use a lot of testosterone. I don't use a lot of injections for some other reasons, but what we can see with the injections, sometimes you can identify IM site tenderness, some swelling, minor erythema. That can be from the physical injection itself, or it can be actually, I've seen it from some of the oil-based mixes that occur with the active ingredient. Rarely, and I've seen this once and heard about it a couple times, you can see someone who has what they describe as a steroid allergy. And up until a few months ago, I really never heard about it, but you can get a little bit of injection site discomfort, some erythema, diffuse rash, and urticaria. A little bit of Benadryl is usually all that's required. Some people who are very sensitive to the testosterone itself, and a lot of females, and we use testosterone for females as well, but all the effects of androgen, hirsutism, acne, oily skin, sometimes alopecia can occur. And you can also see some shifts in fluid and electrolytes and get some lower extremity swelling. When we look at the disease states in urology, try to categorize the type of medication that you'll be utilizing for that disease state. And that will help you organize your thoughts on the kind of medications that you can utilize, and also help you remember some of the potential adverse events associated with this. Alpha blockers bring with medical stone management and bladder outlet obstruction. We can see dizziness, retrograde ejaculation. Most recently, we've seen some data that shows over time that some people may experience some memory loss as well. And remember that Flomax has a unique property where there's some cross-reactivity with patients with sulfa allergies. So use that with caution, or change to another alpha blocker. 5-alpha reductase inhibitors, finasteride. Don't use it that much anymore, but there are people who come to our clinic with that. We know that there's about a 10% risk of erectile dysfunction, which is usually reversible, about 8% risk of gynecomastia, which is touted not to be reversible, and there are concerns of exacerbation of diabetes. When we look at a category of overactive bladder, we use medications that are anticholinergics. Remember from your anatomy and physiology, the cholinergic nerve is the one that contracts the bladder. If we use an anticholinergic medication, it will reduce the overactivity of the bladder, dry mouth, constipation, and in some elderly patients, mental status changes as well. A new category of drugs, relatively new, beta-3 agonists used for overactive bladder. Two commonly used medications, Gentessa. Use this with caution in patients with renal dysfunction, and Myrbetriq in patients who have high blood pressure. It can be used, just modify the dose and be aware of that. Some of the common antibiotics that we use, macrodantin has been utilized for years. It's a great medication. It has rarely been associated, mostly in our elderly population, with pulmonary fibrosis, and that's a big deal. It's irreversible. And so if you have an elderly patient with both renal compromise and some lung dysfunction, you might want to check with the primary care doctor to make sure that that patient is macrodantin safe, if you will. Bactrim, big time antibiotic utilized a lot. The big deal about Bactrim, you don't want to use it at all in patients who are on warfarin or Coumadin. That increases the Coumadin response, and you can have patients who develop a severe reversible bleeding disorder. So Bactrim really is something you want to stay away from. You do see in some guys a Bactrim rash that's almost unique to Bactrim. We see that in the glands where you get a lot of discomfort, glands penis, you get a lot of discomfort, pain, and redness. Discontinuing that medication, a little Benadryl and over-the-counter low-dose, short utilized steroid cream should address this. Aminoglycosides, obviously, the two big issues are hearing loss and renal impairment. So make sure you're monitoring those patients for this. Quinolones is an antibiotic that is really overused. One, it fouls up our coverage, and when you use that as a go-to antibiotic for any UTI, you get a lot of resistance, and then eventually we run into trouble where there are not many PO medications we can use for people with straight forward UTIs. So try not to use it. It's associated with C. difficile, and it's also been associated with ligament disorders, weakness, rupture, and pain. Clomid is a medication that's used off formulary. I use a ton of it for my fertility patients, and I use it a lot for patients who are wanting to have testosterone supplement, appropriate candidates for that, but they want to maintain their ability for good fertility in the future. Another discussion, a lot of information on urology school tapes previously, and on your AUA website regarding other forms of Clomid or other forms of testosterone when we use Clomid. But the things that when we do use Clomid, make sure your patients understand that it stimulates the testicle, and sometimes you can sense a little bit of engorgement, growth, or discomfort of the testicle, not significant. Sometimes GI upset, you can take it with food. Gynecomastia is a big deal. If you're estradiol, remember that's a breakdown product from testosterone breakdown, it can cause increased gynecomastia. And there's been some rare reports of breast cancer in men on Clomid. Very rare, but you always want to caution the patients on that. And another rare side effect that I've seen a few times is blurred vision. I'm not sure why that occurs. It does occur. Rarely, it's irreversible. It apparently is not significant for the patient. I've had one or two patients who've had blurred vision. They're not bothered by it. It's usually nighttime where they're seeing lights, headlights from cars coming at them with a starburst appearance. I've had two patients in my career who've elected not to take it. One was a military fighter pilot, and the other one was in military involved with as a sniper, as a shooter. And those are guys who needed to maintain their eagle eyes, and I understand that. Another class of drugs, PDE5 inhibitors. We see simple stuff like nasal congestion, flushing, headaches, some back pain and large muscles can occur, and we occasionally see color distortion, a blue-green color blindness. That's short-lived, it's self-limiting. It usually lasts as long as the medications are in the bloodstream, and it's normally associated with Viagra. And very important, the last adverse event with PDE5 inhibitors, 100% of the time, the use of any PDE5 inhibitor is contraindicated if your patient is on nitroglycerin or isosorbide, or will find themselves using amyl nitrate, which is used in cardiac facilities, but it's also used on the street. Amyl nitrate poppers touted to improve or enhance orgasm. The problem with utilizing those medications and any of the PDE5 inhibitors is that those patients can experience really bad sex. It's so bad, they'll die. Absolute contraindication. Save your patient, save your medical license, and make sure that you caution that patient, the use of those medications, and document it every time you see them when you're talking about PDE5 inhibitor use. So just a little bit of the skeleton of the basics of the adverse events that can be associated with the medications we use. Obviously, you're going to develop your own list and unfortunately see them yourself with your patients. The trick is to identify them and treat them appropriately. As always, refer to these videos, the AUA, American Urologic Association website. There's a ton of educational material available, and always speak to your urologist who's trying to get you along in this training. Dr. Bill with just the tip of urology school.